So welcome. My name is Christine. I am the project coordinator with the Kawartha Lakes Haliburton Ontario Health Team, and I will be moderating this session today. So welcome to episode 6 of the KLH OHT Lunch and Learn series. And today our topic is the East Region Virtual Care Clinic. Everybody see my slides just to confirm again, please? Yes, thank you.
Yes.
Okay. So today's agenda is we'll be talking very high level overview of what an OHT is, and we'll introduce Marie and Christina from the Durham Community Health Center, who will be speaking about the East Region Virtual Care Clinic. And then again, we'll have time for questions at the end. So for those of you who are just joining us for the first time for a lunch and learn, or who are not familiar with what an Ontario Health Team is, an Ontario Health Team is a collaboration of service providers working together to ensure patients receive the right care at the right time in the right place. Oh, sorry, and I've missed a slide here. Um, Our OHT plan, the Kawartha Lakes Haliburton Ontario Health Team plan, is much the same as other OHTs across the province, and we have sort of three main buckets of work, which is advancing integrated care, advancing digital health, and engaging in primary care. Our primary focus currently is supporting primary care. Um, Stephanie, can I ask you to just jump in and speak to that quickly? I don't have my notes.
Sure, no problem. No, across the province, we've all pivoted in the last year to really focusing on supporting primary care and advancing the spread of interprofessional primary care teams. So that's a big focus is to ensure that patients across our region have timely access to primary care, which are physicians and nurse practitioners and other team members to support their care.
Wonderful. Thanks so much, Stephanie. And so now we're going to jump right into our presentation, which again is the East Region Virtual Care Clinic. And Christina Lim and Marie Hamasour are joining us to talk about it. Christina and Marie, if you could just take a moment to introduce yourselves and then let me know when you would like me to advance the slides. So over to you.
Thank you, Christine. Hello, everyone. It's great to be here. It's a pleasure to be here to have this opportunity to present our East Region Virtual Care Clinic, who, of course, we're working very, very closely with all our OHTs, especially in the East and Northeast. My name is Christina Lim. I am the manager of the what we call ERVCC, East Region Virtual Care Clinic. I am a nurse in background. I've been with the program um, ERVCC for about 2 years now. The first time being a program coordinator, and I just stepped into the manager position just 3 months ago. So I'm quite familiar with the program, having grown with the program as it expanded over the last year or so. I have my colleague here, Marie Hamasour, as well, whom I'll get her to introduce herself. I do apologize. I have a bit of a cold, so Marie will do most of the presentation for this afternoon. Thanks very much.
Hi, I'm Marie Hemisour. My background is healthcare. I am a nurse from since a long time, and was retired, but then Christina talked me out of it, and now I'm working with her since December of last year. My background is critical care, and I also have a role in the IT portion or health informatics. So, in our clinic, Christine and I more or less partner to be able to kind of guide the clinic through its day-to-day operations, but then look at opportunities for us to improve access to care in the community and work with partners to be able to complete that for our patients and our people in our regions. So I think we'll start with the presentation. So if you want to go on to the next slide, Christine. So the East Regional Virtual Care Clinic, we sort of launched in sort of our new setting in August of 2023. It is a free nurse practitioner led virtual care clinic, and we work with local health care providers to ensure patients have more access to timely care. We serve clients with or without primary care providers, some that are attached, some are poorly attached, or the unattached, and with or without a health card. So um, we don't say no when if they don't have a health card per se. The mandate originally, and this kind of grew out of the whole virtual care sort of grew out of the COVID pandemic in the fact that we wanted to reduce the CTAS 4s and 5s from the ER and the Ontario Health ED diversion strategy. And so we're more or less starting on that foundation, but now improving and uh, basically looking at what our next iteration is going to be as we journey through this whole issue around primary care provider access and access to care. Next slide. So again, the history is uh, we kind of built with the Urgent Care Durham and kind of partnered with them under their umbrella, although ERVCC is an entity under this umbrella, but we partner for the Ontario Health East, the East Region Virtual Care, and the Northeast as well is in this. They can now, that we have website access where people can access or apply for a appointment, and it is across Ontario from like the Pickering border all the way to the Quebec border, and then north up around into the like north up for the northeast region up to the St. James coastline. So we have some maps coming up. So that's kind of like we we sort of work with the DCHC to basically expand our access. Next slide. Our hours of operation are 7 days a week, 365 days a year from 1 p.m. to 9 p.m. Um, our appointments can range anywhere from 5 minutes to 30 minutes. Some can take an hour. If you can imagine, we have a lot of patients that are have lost their primary care provider, and they're usually elderly or older with multiple comorbidities and a medication list that goes into like next week almost. So some of those calls can take up to an hour as we work through what their healthcare needs are. We do both video and phone audio calls. Patients are able to upload documents like medication lists or photos or whatever is needed for that interaction. And we use Oscar Pro as our EMR. Cortico is a company that we more or less partnered with. They handle the website, the notification platform, and the video platform. And we make our community referrals through Ocean, and we use voice for our translation services. Our web addresses, we have both East and Northeast Clinic web addresses, and we have one phone access line for both of those clinics. So the next one. So we have inclusion and exclusion criteria. As you can imagine, there are things that are just not appropriate for virtual care because, so basically on the left-hand side, We treat things like urinary tract infections, sore throats, skin problems, stomach, like if somebody has some issues with, mild stomach pain without a fever that's happening less than 2 weeks, any mild to moderate headaches, respiratory, and especially around surge now, respiratory coughs and colds. We handle a lot of respiratory, sinus infections, dental problems, and prescription refills. Now, the prescription refills, if you go to our not appropriate for ERVCC, we don't prescribe narcotics and controlled substances. That is like a policy that we've adapted, and I don't think most virtual care clinics do that as well. We anything that needs like any type of on like diagnostics and stuff that need to be handled like at the time of assessment or needs a hand-on assessment. So if you have people that are COPD or asthma, but they're if they're mildly affected, we can deal with it. But if they get into where they're having an extreme exacerbation of it, then that usually requires a ED or an in-person visit. So anything neurological that, stroke related, reduced levels of consciousness, any types of paralysis and stuff like that needs to be seen immediately because, having said that, they probably need some type of advanced diagnostics for the find the root cause of what is causing their problems. Um, any infants under 3 months with a fever really needs to be seen, and infants 3 to 12 months that have a fever that's 3 or more days should be seen in person. Um, there is a little bit of kind of the art and science of triage here because um, like sometimes they're like kind of on the cusp for respiratory, and we feel that they may need some like additional diagnostics, and not necessarily we can treat them. Okay, next slide. So the medical refill schedule is we have specific days, and we found that through our surge season last year that grouping medication refill days on Wednesdays and Sundays was a little better. It provided a little bit more structure for our team and for the patients themselves. So we basically broke that up and kind of concentrated 2 days a week. And during our holiday season, we'll probably add a day or so extra in there around medication refills because, of course, as everybody knows, that's when around the holiday season is when outside visit like clinics and stuff and doctors' offices tend to close. So we sometimes are like the last resort in town to be able to get a medication refilled. Our sources of referrals are usually self-referrals by phone or the website. Um, we have Health 811 will send us. We have some partnerships with community paramedic programs, and we're sort of exploring that with you now. Our pharmacies in areas will give our numbers out for medication refills, and then other healthcare providers. Sometimes some physicians who cannot see their patients in a timely manner will tell their patients to call us to have their needs met. What we do afterwards, so the visit dispositions, we can refer to specialists. Sometimes we, if especially if a patient's unattached and they need a specialist referral. This is also very uh, prevalent in our mental health patients. Sometimes they need more medications and all that, and they need a referral to a psychiatrist or a program that can help them with their antidepressants and reordering different ones. Any diagnostic and lab work, we can order that. We do follow-up appointments with our ERVCC or their own primary care providers, depending on what they're being seen for. Sometimes we like to check after a few days to see if the treatment that we have on the treatment plan providing relief for that patient, especially with our pediatrics. We tend to check on them a little more often. We can redirect to inpatient ambulatory walking clinics and then redirection to ED if the situation needs that or warrants that referral pathway. Next slide. Here's here's our the East region catchment area, and we divide them up in East region and Northeast region because we have to report numbers specifically to both regions to the ministry. So we have actually two clinics, and this is the East region, and it encompasses all these OHTs in this region. So we serve the Pickering to the Quebec border and north to Deep River. That's up on like kind of the Ottawa Valley panhandle there. Next slide. This is the Ontario Health Team Northeast catchment area, although I couldn't find one that kind of showed all the different OHTs, but I know like Algoma OHT, Mamawassing is here. I think Nipissing, there's different OHTs, and it goes up to the St. James border, like lake border there, and to the west where it hits on to the Northwest Clinic, which is handled by another OHT. Okay, our next slide. This is our clinic structure and governance and partnerships. So in our leadership, our VP of Integrated Care and Experience and our Chief Privacy Officer for the DCHC is Melinda Wall. And as you know, Christina is our manager, and then I am the program coordinator. Our Ontario Health East lead is Sophie Otar, and we have 5 medical secretaries. We have 1 RN lead system navigator, and then we have 14 nurse practitioners currently. And we have partnerships with these nurse practitioners, like 3 of those nurse practitioners belong to the Mamawassing CHC. And then we have another 3 that we, for the CE Elistry, that's near the Quebec border. We have 3 of theirs MPs that work within this 14-member team, which is quite wonderful because the Elistry, that area is highly French speaking. So these MPs are French speaking MPs, and that can service that community quite well. So we're very pleased to have them on board. The diversity of their expertise is we have MPs that are in primary care, emergency care, pediatrics, internal medicine, critical care, geriatric, public health, academia. We have a very diverse team of MPs, which is really great because we have a lot of sharing of knowledge and a lot of discussion and a lot of like cross-pollination within our team. We have membership on the regional EAVC Community of Practice Committees. So 4 of our MPs do sit on that committee and provide their knowledge and some navigation support to that regional committee. And then we work closely with OHTs and community paramedics to advance access to care. Next slide. Here are some statistics. Hopefully, you can kind of see them. The statistics on the top are for the East Clinic, the 2004 and 2005 fiscal years, and then this fiscal year to date. We last year to this year, we've had some with the ministry, as you all know, every year they come out with new requirements and data requirements. So the amounts from the year previously, we had some realignment. So there is a little bit of a difference, but really and truly, they're there isn't too much. It was about what cases qualify and what doesn't qualify. Basically, it's almost like a 60-40 split between unattached and attached patients, or patients that are like uh, poorly attached, or their PCP or just wasn't available for them when they needed help. Yearly, from the 2024 to 2025, we've seen about 18,000 visits in the east and about 5 to 6,000 in the northeast. And we're probably tracking to be the same amounts by the time our surge hits. And that will probably end up being around what we'll be seeing this year. So are there any, if we can go on to the next slide. So thank you for allowing us to present. Are there any questions that you have for us that we can answer?
Thank you so much for that presentation. That was a really great overview of the East Region Virtual Care Clinic. We'll just start by maybe in the chat. I think there was a couple of questions here. Um, so the first question is, are folks able to use WhatsApp or other VoIP to connect with ERVCC?
No.
Okay.
Yeah.
Oh, I think Christina answered that in the chat.
Yeah.
Thank you, Christina.
We use WhatsApp in our team as a very dynamic daily kind of like, as our MPs and stuff. So WhatsApp is used within our clinic as a communication tool between the team. So like, especially for community paramedics, if they call in, then the admins will in the WhatsApp chat tell the NPs that there is a community paramedic call, because we realize that community paramedics are usually with the patient and we don't want to keep them off the road long. So we have a very, like I think it is, Christina, I think it's 15-minute.
Uh, sorry, 15-minute.
I think
Oh,
it's a
you mean,
15-minute
oh,
timing there.
right. You sorry.
Yeah.
Within the call, within 15 minutes of the call of the paramedics that we prioritize when they do call.
Yeah, so
Yeah.
that they're seen, because a lot of paramedics are on the road, so we don't want to keep them at a bedside for, right?
hmm And we have to make sure that whatever platform we are using for our video or audio calls, that they are heavily integrated, or that they are well integrated with our EMR,
Mhm.
because a privacy and confidentiality issues, but also because of information sharing. Some patients upload their pictures, so if they're not able to use video, for example, our NPs can assess through pictures, as long as the reason for visit is suitable for a virtual care clinic appointment. So there's information sharing between the patients as well as our NPs, and also being able to prescribe, sending information to pharmacies as well.
Mhm.
And of
Great.
course, the documentation by our clinicians.
I think I just saw a question about how we're being um, uh, marketed.
Yeah, how
Like
is the
that.
ERVCC being promoted, and is it available to all residents in the supported areas regardless of whether they have primary care or not?
Yes, we will see anybody with or without a health card number, with or without a primary care physician. Um, we do notify if the patient has a primary care provider, we will notify the provider of their visit. So in case they want to follow up. So um, I guess for the last 6 months, we've been sending out faxes to those providers to notify them of the visit. How we're being marketed, we're sort of in, we had a marketing about before I joined the team anyways, they did market, but I think it was on a very kind of a small, um, like to some pharmacies and whatever. We're now working with the OHT and trying to, like, we're putting together a marketing plan to go out and to market a little bit more. Um,
And if I could just add to that, Reed, just specific to the Kawartha Lakes Haliburton Ontario Health Team, we have the ERVCC listed on our KLH OHT website, and we're working to make that a little bit more visible. We have
yeah.
a phone number on our website that people can call if they're looking to be connected to programs or services. And oftentimes we get calls from people that don't have a family doctor and want to know where they can access care. And they're often referred to the East Region Virtual Care Clinic. And as a team, we did extensive outreach to pharmacies and community bulletin boards and places where people tend to congregate. And we had some promotional materials put up around Kawartha Lakes and Haliburton. So
Mhm.
we've been working to promote it from our local OHT as well.
Yeah.
There's a question, is there a wait time or a priority schedule?
We tend to we see most of our patients same day when they request a when they request a visit for us. We see them typically same day. When we
Mhm.
get into surge, however, that might end up because sheer volume will dictate, and then we do prioritize some calls. So, in children, elderly, respiratory tend to be a little bit higher priority than some other things that are like, one-offs or
Mhm.
smaller, like even that's why we instituted having specific med refill days is to take them out of when the surge happened so that we could focus on those on a couple of days and then leave up spaces for more of the high priority respiratory things that had come through.
And of course, our calls with the community paramedics are also a high
Yeah.
priority, just because they need to be with the patients at the time that they are calling us.
Yeah, they are like probably the highest priority we have as community paramedics because of the fact that you're like on the road and we can't take an ambulance and a community paramedic off the road for any length of time.
All right, thank you.
Yeah.
We have another question in the chat. How are any follow-ups managed? So, for example, if a prescription is initiated.
We're very strict on some of the prescription initiations to begin with, because some of whatever you are initiating a prescription, there are different follow-ups or guidelines that have to be followed. So a lot of our initiation, depending on what it is, we will send them for their first to a walk-in or whatever to get them on the medication. Then any renewals, if they are stabilized on this medication, we will we will basically fulfill those portions, right? Follow-ups are done by at between the MP and the patient themselves. So it's kind of like it's a professional practice thing. If you're starting somebody on something like an antibiotic or whatever, you may want to see them in 3 days. So the MP at that point in time will say them, I want to see you in 3 days, and she will send a request to the administration to the medical secretary to book them in a 3 day to follow up with them. And we have some patients that we have been seeing regularly because they don't have primary care providers. They need medications renewed. And some of them, because before when we started, we were seeing a few or a lot more mental health patients and stuff. And some of those mental health patients do not have primary care providers, but they're well established on their antidepressants. Okay. So we do see those ones because we don't want them orphaned and off their medications in the community. Like you can appreciate the safety aspect of that. So those people, when they book in every 3 or 6 months, we will do the GAD scores or the PHQ scores and then renew their medications. But the underlying is how stable these patients are on the medications they are. And we typically, and it's an MP call when it comes to medications that are critical or higher critical type medications, whether they will send them to a clinic or not. We tend to really be careful when we're insulin ordering and stuff because it really should be done in like a diabetic education or like that type of diabetic clinic or stuff because when you have medications that are like need to be titrated a lot, it's not really good for the virtual. They need more of a visual and a hands-on because you want to be able to assess them more. So a lot of this is kind of the art and science of healthcare in a way that, when the NP is then assessing the situation, whether she feels that if it's a follow-up, then there's a discussion with the patient and then the timing for that follow-up because we're going to have to call them anyways, so they have to be available on that day. And as our clinic is Christina is know, as we are evolving and changing, we're starting to kind of change our aspect of like now offering more booked appointments. And so that people know that we'll be calling them at a certain time, give or take 15 minutes on a day so that it's a lot more, you don't have people like, waiting in the bathroom at work for a call or whatever, like that type of, so we can be a bit more specific to the patient and a little bit more organized that way. Christina, anything else?
Thank you, Marie. Depending also on the types of medications that they may have. So, for example, if they are on a thyroid medication, and our NPs also look to other e-health clinical viewers, for example, Connecting Ontario, just to see any other history or information about the patient. We want to make sure that we also have a baseline. So if a patient is on a thyroid medication but has not had a lab work just because they may not have had been followed by a primary care provider, then our NPs will also order a lab requisition for baseline lab work for patients, just so that for ourselves, we have a baseline for the patients so that the next time they come for their medications, then we already know how we could adjust those medications based on some of the lab work, which, they should be having some of these lab work depending on these medications as well. So
Yeah,
that's part of the services that we provide to our patients. So
yeah,
they do not fall under through the cracks just because there's no continuity of those types of monitoring.
yeah.
Can I ask a
And I think
follow-up question? If somebody is prescribed a medication, doesn't need to go to a clinic or they need to get blood work, how does the person calling get the prescription or the requisition for the blood work, for example?
there's a couple of ways. With our Cortico plug-in, we can send them their blood requisition through that. So as the MP fills out the blood requisition, then there is a feature that we can send them that blood requisition. It goes to the cortical portal for that patient. That patient then themselves have to identify themselves as they are themselves, and then they can print it off of we can also send the requisition via electronic intake into Life Labs. And I think Dynacare also has that ability to accept electronic requisitions as well. So that's how that can be sent. We ask for when the patient registers for maybe a prescription renewal, we ask two things. We ask their preferred pharmacy, so where they've been getting their medications. And we ask that they send us the a 6-month ordering summary from the pharmacy. So the MP can look at not only the medication that they've requested for renewal, but how many renewals they've had in the past, and if there's been any adjustments in those medications up or down. So it gives them a good idea of what they've been on, what they are on, how long they've been on it, and then we also our RN navigator usually does when she's right off on maternity leave right now, but when she comes back, she does the best possible medication reconciliation for us. So that, because you can imagine that we have patients, we have such a big catchment area, and we have patients in certain areas that are elderly that are polypharmacy. So they may call in for one medication that needs to be renewed, but they're on 17 different medications. And so that best possible medication reconciliation is very important because you want to know whether they're taking their medications appropriately and on time, you know. And a lot of these people that we end up picking up are really primary care that have had an episodic episode because they've lost their primary care physician and they haven't had the necessary follow-ups that is needed for the medications they're on. So, some of our MPs will end up, that's how we end up finding those individual people that really do need to be hooked up to a primary care provider, probably before other people in the province, because they really have, a lot of comorbidities.
Right.
They're testing our emergency system.
I
So
did hear something in the background. Yeah.
yeah.
Thank
So anyways, yeah. So that's like kind of the what we do. In our practice, our MPs, to make sure that they're not only getting their medications and that are, but not only are they getting it, but they're getting it safely, and we're observing those best practice guidelines that we need for our standards of practice and stuff in medication renewals.
Great. Thank you, Marie. Are there any other final questions or comments?
Christine,
Yeah, Julie.
hi.
Hi.
It's Julie from Corth Lakes. I chimed in late, so I apologize, and I
Okay.
apologize if this has already been brought up. I just kind of caught a little bit of it, and I kind of caught what Christina was saying regarding kind of community paramedics. Like, say we have somebody in the community and we're looking for some kind of advice or prescription. Is it just a number that we call into to hopefully get somebody?
Yeah.
Yes. If it's a call from the community paramedic, they can just call right into the clinic, and they just need to identify themselves as calling, we're the community paramedic, and they get prioritized, highly prioritized as a call. So then we let our team know that there's a paramedic call so that one of our NPs can go directly and interact with the community paramedic call with the patient.
And that is just the same number that's just on the website, correct? Yes.
Correct.
Amazing.
Yes. Yes.
Amazing. Thank you.
And Julie, just a shout out, the OHT is working with the ERVCC to strengthen that relationship and ensure that you guys are more than adequately resourced with that NP support whenever you need them for whoever you need them for.
Yeah.
Well, that's amazing. Well, yeah, we'll make you strong. Don't worry.
Great. Any other questions? Okay. Well, thank you so much to Christina and Marie for joining us today and giving us such an excellent presentation. It was very informative, and being able to answer all of our questions. I'm just going to share my screen quickly again. And just as a reminder to folks, if I can, apologies. You can explore our past Lunch and Learn sessions anytime. You can just visit the resource tab on the KLH OHT website. And we would love your feedback. So if you attended today's session, please watch for a short evaluation survey in your inbox soon.
Mhm.
So thank you, everybody. Thank you for joining, and enjoy the rest of your day.
Okay, thank you.
Thank you.
Thank you very much.
Bye-bye.
Thank you. Bye-bye.